Jeffrey, thank you for joining us, and congratulations on being selected for this year's Donner Prize Shortlist.
Pleasure.
Jeffrey, tell me, what was the impetus for you to begin writing Chronic Condition?
Well, I've been listening to the way Canadians have been talking about healthcare for a long period of time. And I was increasingly unhappy with the fact that I thought a lot of elemental truths about the system weren't being talked about. So public policy wasn't being properly addressed. We kept being told that we had the best healthcare system in the world, and I was kind of scratching my head and said, is that true? And then I began to look at the international evidence, and there's a lot of it, and clearly our system is a long way from being the best. I was unhappy too because we were spending more and more money on healthcare, and I didn't think we were getting commensurate results. So why was that? I thought I should look into that. So it was really out of a sense of frustration that the public debate about the #1 issue, Canadians say it's the #1 issue, I didn't think was on the right track. I think it now is for a variety of reasons. I'm not immodest enough to say that it's because of my book, but I think for a whole lot of reasons people have come to understand that our system is a long way from being the best. It's an expensive system, and that we need to make some serious changes.
As Canadians, we enjoy comparing our healthcare system to that of the US, but yet you throw that comparison out. Why is that?
Well, the U.S. has a system that's largely private, okay? So 45% of all the dollars the Americans spend are publicly spent, and the other 55 are private. We have 70% public, 30% private. So there's no effective comparison between the two systems, but it suited the unreconstructed defenders of our system to keep referring to the U.S. Because after all, the U.S. spends 17.5% to 18% of its total national wealth on healthcare. We spend about 11.6%, 11.7%. So they're spending 50% more, and they're not getting 50% aggregate outcomes that are better. So why would you adopt the U.S. system? It's crazy. So that was a false comparison. Different system, different set of principles. The right comparisons are with other countries that have largely public healthcare systems, i.e. all the countries of Western Europe, Australia, New Zealand, Japan. Those are wealthy, industrialized, westernized countries that all have public healthcare systems. So you want to look at how we're doing vis-a-vis them. And it doesn't matter what study you look at, whether it's from the OECD in Paris or whether it's the Commonwealth Fund in the United States, Euro-Canada Barometer, you find two things. We're in the top 5 when it comes to the amount of money per capita we spend, which is no bad thing, because all rich countries spend more on healthcare than poorer countries do. But when it comes to outcomes, medical outcomes, patient satisfaction, etc., we rank in the middle at best. So we've got a big gap, and that's why, metaphorically, I said we've got a system that costs like a Cadillac but delivers like a Chevy.
You do suggest a number of reforms in your book, many of which contradict the usual political thinking. How do you think these will be received?
There's a group of folks who've dominated the debate for a long time, and they won't like this book, and they won't like these some of these reforms, right? Because they believe that more centralized planning and more money in the system is what's required, and they will be very defensive about it, okay? They've been dominating the debate for a long period of time. I think their time is just about up, because we've tried that solution. Remember, we were told that we should buy change 10 years ago, put a lot more money into the healthcare system, and Paul Martin, Prime Minister at the time, and the premiers did so. $41 billion, indexed at 6%. I would love my income to have been increased at 6% per year over the last decade. And that was supposed to buy change. Well, you'd be pretty hard-pressed to say that all that money, that's the biggest public policy bet of our generation, actually produced the kind of change you would expect for all that money. It didn't. Why? Well, first of all, the providers, as could have been anticipated, grabbed a lot of it. The doctors and the nurses. They were organized, they were mobilized, they saw new money, they made a claim, and they were rewarded. That didn't make the system any better. It made them better off, didn't make the system better off. Anyway, so we now know what not to do, which is to spend additional sums of money. So I'm actually guardedly optimistic that we've got that message. The public has it, and political people have it, most political people. Now, what I fear will happen is that election campaigns will go back to where they used to be, where parties bid against each other for how much more they were going to spend compared to their opponents. We know that doesn't work, and so I think we've got wisdom, and I hope so. Now what's going to happen, and is happening, is that as the healthcare budget's increases come way down, in Ontario from 7% to 2%, in Alberta from 9.5% to 3%, New Brunswick freezing, Newfoundland freezing, etc., you're going to have to rely on creativity and new ways of doing things rather than saying, hey, the answer to our problem is to course a lot more money into the system. That isn't available. All governments are in deficit except Saskatchewan. Economic growth is going to be slower in the next 10 years than it was in the last 10 years. Mr. Harper's already said he's going to be reducing the increase of federal transfers, and we know the population's aging. And an aging population will increase the costs on the system and have fewer people in the workforce we can tax to pay the bigger health care bill. So for all these reasons, anybody who thinks that the next 10 years can be like the last 10 or 15 hasn't been reading the tea leaves correctly.
In your book, and I quote, you say a dollar spent on poverty instead of the existing healthcare system or even some public health programs would be the best long-term investment not only in health, but also in lessening cost increases. This is certainly less of a head-on approach to healthcare reform, wouldn't you say?
Okay, here's a dollar. Okay, you want to do something for healthcare. What should we do with it? I would say do not spend it on the healthcare system, because if you look at who uses the healthcare system and what drives the healthcare system, there are many drivers. But one are people who are on low income, who disproportionately have healthcare problems and therefore disproportionately use the system. So if you can reduce the number of people who are poor, you will lower the costs over time on the healthcare, over time, this takes a long time, okay? You will lower the costs on the healthcare system, to say nothing of improving the lives of people who are in some degree of distress. So I think among healthcare analysts, what I've said actually isn't very controversial. The challenge, if I can put it politically, is that most people want their healthcare system to deliver healthcare to them now, when they want it.
What do you see as a realistic timeline for change?
I think it's starting now. I mean, I think that the financial pressures that governments are under is making them impose or induce change in a way that when there was a lot of money, there wasn't. What does that mean in practical terms? Well, it means, first of all, changing to some extent the scope of practice. Things like pharmacists are being given more authority to fill prescriptions, etc., to do various kinds of testing, because they can do it at a lower cost with no safety problems for patients. I think you're going to see more nurse practitioners. I think you're going to see more money at the margin being spent on home care, long-term care, nursing care, and less in acute care hospitals. I think you're seeing the collective bargaining agreements with the providers, nurses unions, physicians associations, far more reasonable than they were 5 years ago, et cetera, et cetera. So I see a lot of things happening, and I've been at many conferences since this book came out with healthcare professionals and administrators, and they're aware of the fact that there aren't big stacks of cash waiting for them, and they are thinking about ways of changing the system, et cetera, et cetera. There's some barriers we haven't yet gotten over, which other countries long ago have. One of the things that strikes you when you look at other countries and what they're doing is how much they've been prepared to change and experiment, and we haven't. We're behind the change wheel vis-a-vis Sweden, vis-a-vis Britain, vis-a-vis Australia, New Zealand. We're catching up all the time because we were rooted in this way of looking at our system, which was part of who we were. And the other countries that didn't have that aspect to their system were able to change their system more dramatically. So one of the most controversial words, in fact, the most controversial word in Canadian healthcare is the word private. It sends people into conniptions. You know, they run to their ideological barricades and they say, oh God, it's U.S. medicine, here they come, right? You've got a hidden agenda. And you kind of look at other countries that have got beyond that and said, look, what we're interested in is patient care. And if a private deliverer can do it better, paid for publicly, as in Norway, as in Sweden, as in the United Kingdom, well, let them do it. We'll monitor, we'll license, and we'll pay, and somebody else will provide. That is still a hill that a lot of Canadians find too tall to climb up. I think it's inevitable it's coming, and I think we look around the world and see that others have climbed that hill, and they haven't died on it, and we in due course will climb up that hill. I mean, why the H in acute care hospitals have we got hip and knee replacements being done there, which are 95% extremely routine, fighting with cancer, neurosurgery, and other serious surgeries? What is that? That's ideology. That makes no sense. These should be farmed out to specialized clinics that do nothing but that. and they sign a contract with the state monitors, regulates for quality, signs the contract, better patient access, same outcome, and lower cost. If you can meet those three tests, cost, outcome, and access, why not have private providers do it outside the context of acute care hospitals?
Well, what do you hope are some of the results or outcomes that may come from people reading your book?
I think over the next, as I say, 5 to 10 years, you're going to see major changes in how healthcare is administered, financed, and delivered, because we cannot continue to just throw money at it. We're always going to spend a lot, but every year we can't spend 6% more of our national wealth, because that takes money away from other things that we'd like to be spending the money on. So I think you're going to see changes in delivery and changes in finance. And I think you're going to see more private delivery of publicly paid for services. I think you're going to see the scope of practice issues change somewhat. I think you're going to see physicians paying more attention than they already have, and they do pay a fair bit, to quality. And it's going to be measured in terms of patients and the outcomes they have.
That's great, Jeffrey. Thank you for joining us, and congratulations once again.
Thank you very much. Pleasure.